So we have.
Good afternoon, everybody.
Yes, we'll have the next talk by Dr. SUBHENDU BORAL with submacular hemorrhage.
Submacular hemorrhage, lot of dilemmas, lot of permutation, combination of treatment. We should know what are the important etiologies. It's a neovascular AMD, PCV, trauma, and ruptured mechanism. There are 4 principal causes, and treatment strategies depends on the size of the hematoma, duration of the blood, and distribution of the hemorrhage. That is also important. So let me tell you one thing: less than 1 Dix diameter submacular hemorrhage doesn't consider as a submacular hemorrhage because it is a part of CNVM. If it is 1 to 4 Dix diameter, it less than 4 weeks. The small, medium size, and massive is the classification given described in survey ophthalmology. That is small size, less than 2 weeks, anti-VEGF or pneumatic displacement. If it is traumatic in origin, then it is suffices. But it is more than 4 Dix diameter, but not extending the temporal vascular arcade, and the duration is 2 to 4 weeks. So non-drainage procedure by vitrectomy along with this cocktail of subretinal TP, anti-VEGF, and ER injection, it is giving a good result. But massive size hematoma more than 4 Dix diameter and beyond temporal vascular arcade more than 4 weeks, drainage techniques are important, where you have to go for the subretinal TPA, retinotomy, and subretinal blood removal. And if it is you can do it either retinotomy or by the temporal retinectomy also, or it is more than 8 weeks, you can go for the RP choroid patch graft transplantation as an added procedure. So ideal indications situation for subretinal hematoma, it is massive thick subfoveal, predominantly infundibulous subretinal hemorrhage, and the tissue plasminogen activator which is present inside our eyes normally, it is in the aqueous humor, trabecular meshwork, lens, vitreous, conjunctiva, and commercially it is available as a altiplase, retiplase, technetiplase, which act on that activated plasminogen activator. It converts the plasminogen to plasmin, which acts on fibrin to go for the fibrin degradation product. That's why it causes clot lysis. Like just after giving the subretinal TPA, you can see this kind of beautiful red colored happening of the changing of color that happens in case of any dark colored hemorrhage after subretinal TPA injection. And just after giving air, this buoyancy factor that has an upward action, and this gravity of the RBC that will go down, so that will make the fovea free of blood. So less than 4 weeks duration, confined to the macula or extending inferiorly. In these cases, we are going for the subretinal TPA, anti-VEGF, and subretinal AR injection, and slow one by one. You can see, and in this kind of situation, patient presented with very poor vision, either finger counting or 1 feet vision, and after giving this subretinal anti-VEGF TPA, you go for the subretinal anti-VEGF along with sterile filtered air, so that it can sift the blood inferiorly by its buoyancy factor, and the rest of the lysed blood due to the gravity action of the RBC cells that will go down, that will make the fovea free of blood. Now finally you can see the post-operative beautiful picture, vision improves to 6/12, but sometimes you are in dilemma whether it is vitreous hemorrhage along with subhilar hemorrhage or subretinal hemorrhage. You should go for the to see the high reflective spikes from the anteretinal surface. That means, and there is subtly demarcated, you can see the yellow arrow, it is there, it is arising from the optic nerve head. That means it is retina, it is not subhilar hemorrhage. And like in this situation, presented with the PLPR accurate vision, and the duration of the hemorrhage was 4 to 8 weeks, extending beyond macula. So I planned for the cataract, followed by vitrectomy, subretinal TP, and retinotomy. In this case, after doing the cataract and injecting IOL, there was a lot of hemorrhage, and you can see the hemorrhagic retinal detachment. So I planned for the subretinal TP injection for clot lysis. Now I did 2 retinotomies, one at the infranasal and one to remove the blood partially from the nasal side as much as possible, followed by supratemporal area, from just above the temporal vascular arcade, and remove the blood, do the fluid exchange, and check whether any residual subretinal blood is there or not, and do the laser and injected silicone oil at the end of surgery. So postoperatively, you'll see slowly there is ERM formation that happened after 3 months of the surgery. So then I removed the oil and ERM removal. You can see patient finally gained 6/24 vision. This is another case of hemorrhagic retinal detachment with a lot of vitreous hemorrhage. You can see the blood is tenaciously adhered to the underlying detached retina, and the whole retina is it is almost in black colored. You can see the blood is quite old. It is although it's more than 1 month, but fortunately it was less than 8 weeks. So I did subretinal TP injection, and followed by waiting for 15 minutes time for the adequate clot lysis. You can wait for a range of 10 to 45 minutes, but for the adequate clot lysis. But in this situation, I waited for 15 minutes and removed all the blood, used PFCL for the drainage of settlement of retina, and did 360 laser, and followed by direct PFCL silicon oil exchange using Sandler slide, injecting PFCL, injecting silicon oil with the left hand and removal of PFCL with the right hand. Postoperatively, will get this kind of picture. So more than 8 weeks, that is much more. RP is much more in a compromised situation. So when I did temporal retinectomy, remove all blood along with the CNVM, and CNVM it is very much like, it is very thick, and you have to use the settings of just doing removal of cataract with the setting of that 600 suction and 100 cutting rate. And now I'm injecting subretinal PFCL because you can see the RP is quite compromised. And to keep the retinal flap away from our working site, then choose an area of relatively healthy looking site and used 2 forceps under the PFCL bimanually. I am shifting this full thickness RP choroid graft under the PFCL into the proposed site of the fovea, and graft alignment was done underneath that foveal area, and remove the PFCL, and then inject the PFCL again the overlay anterior to the retina to settle the retina, and do laser all around along with silicon oil PFCL exchange. So postoperatively you will get this kind of picture. Thank you.
Thank you, Dr. Boral. Very nice videos, and very innovative techniques. Do you have any comments to be made from the audience? Anybody wants to have any question?
I have one question to Boral sir.
Yes.
Sir, when you inject ear, whether the first case or second case, how much of ear you have injected?
Yes, 0.03 cc.
0.03 cc.
You should always take care about the volume over the subretinal
So
space.
what will be the volume of TPN and ear?
TPA is 0.05 and anti-VEGF is 0.05 and 0.03 air. That is good enough.
And you inject by yourself or your assistant pushes it?
Basically, I made one new instrument, that is micro VFC, that I have submitted in the ASRS. That 1 ml syringe that will describe in the other micro VFC. And
I
so
think there are reports
that is
of injecting in normal VFC also when you keep the pressure around 5 millimeters.
Yes.
So we have fortunate to see 2 award-winning video.
Yes.